These are our objectives to appreciate the definition, how common the problem is, how do these patients present to us, what are their work risks, how do we assess if this has happened, how do we manage the problem, and what are the other things we should be thinking of that may mimic post-dural puncture headache, and what are the other complications that we need to look out for. From the different societies, this is a headache that follows administration of a local anesthetic, either through a spinal or through an epidural, or just insertion of a catheter in the back of a patient. So there should be history that I had a catheter, I had a needle, a epidural, or a spinal in my back. It normally happens in the first 24 hours to the 5 days. But we've had cases, actually, a referral from Gulu and a referral from Case Clinic that I manage privately, who had incidences of post-spinal headache after 6 months. The patients will classically tell you that, doctor, every time I sit, the headache comes within 15 minutes, and when I lie down, again, the headache takes some time but disappears. These headaches also have been noted that they can disappear within the first 7 days without treatment. We have a higher incidence in Uganda. Dr. Numbers in 2016 did a study where she found 48%. Around the same time, in 2016, someone in Ethiopia did another study which had showed slightly lower incidence of about 42.6%. Other countries, UK has 1 to 4%, Canada has almost about 2%. So we still have a big problem. And the big problem one person has identified
Dr. Aggrey, we've lost you.
I can't seem to move them now. Okay, I've gotten back. So I was sharing that the prevalence in Uganda is quite high because the studies, first of all, could have been skewed because it was done in a medical training school. That was the old Mulago training school, where you have different users, both the anesthetic officers, you have students, and then the clinicians. But also the same thing happened in Australia, in Ethiopia. So probably it would be a very good thing to do both training and non-training hospitals to see the actual prevalence, and we compare and see where we are as a country. But by and large, it informs you that the biggest training school by then had that incidence, and it means we are either, the risks are the needle sizes. I've taught KIU students who told me and confessed that they had never seen a spinal needle until when I told them and showed them, and they had been using cannulas 17, and that was Hoima Regional Referral Hospital around 2019. So several years, but things have greatly improved. But yes, it's very true that upcountry people have tried to use even gauge 22, the pink needles. So the bigger the size of the needle, the bigger the hole you've created on the dural puncture. Then also, even if using a gauge 25, if you keep on pricking many times and you're failing, you're pricking many holes, and that means you're going to have a lot of CSF leakage. By and large, anatomically, women are more at risk, and the younger they are, the more they are at risk, normally between 20 to 40 years. Also, the people at risk are those who have lower BMI. When you have a bigger BMI over 30, you have less compliance. That means you, because of the fat that surrounds your spinal canal, it kind of compensates. Even if you change position, there'll be fat squeezing on the cerebrospinal fluid, so it doesn't drop. While smaller people have a more compliant spinal space, so they tend to be at risk of this headache. For patients that have had a history of post-dural puncture headache with a past spinal, it's like PPH, they normally tend to have that risk. So normally the risk is over 5%. So it's good to tell them that we are not guaranteeing, even if you use a smaller needle, but you might still get a headache. Also, patients that have had history of cephalgia of pregnancy, which happens about 17% of mothers, or history of migraine in pregnancy, they are most likely going to have a problem. It will also be noted mothers that come dehydrated, like prolonged labor, they have a contracted volume of distribution of their cerebrospinal fluid. So when you give a drug, you're giving it in a very contracted volume, and it will end up getting them a risk for headache. Then it also be known that we tend to get emergency patients more at risk compared to the other patients. Typically, our patients will complain of nausea. The majority will complain of annoying nausea. There will be those that will be vomiting. Then they have a stiff neck, as if someone hit them at the back or they made them lift a sack. Then they may have ocular symptoms, which will be either diplopia or visual blurriness. And then they'll have auditory symptoms, which is typically buzzing in the ears or tinnitus. The type of needles I've showed, we have a sporot, we have a Whittaker, we have a Quinky. A Quinky is what we normally use in Uganda, and it has a cut edge. In private practice, you may come across a Whittaker, which is a pencil point and a sporot, and the holes are on the side. So these really do less trauma on the dura membrane as opposed to the one that cuts through. And typically, if you're using a Quinky needle, we prefer it goes in on the lateral side so that you separate the fibers, as opposed to when you take it looking up and then it just cuts through the tissue as if you're doing a biopsy. The nerves that are affected when you get a post-dural puncture headache will be the trigeminal nerve, and that's why you get the frontal headache. Then the C1, C3, C1 to 3, and the cranial nerve 9, 10 are the ones responsible for giving you the neck and shoulder pain or the occipital pain. The vagus nerve is also able to give you nausea and vomiting. So this explains the kind of symptomatology all these patients are having because of the effect this has done on the drug. The mechanism: when there's leakage of CSF, there's going to be decreased volume, and the decreased volume is going to cause decreased pressure. And if you remember the Monroe doctrine, where they say the sum of the intracranial structure should be always stay in balance, and if one is offset, then the other sums should be able to balance out. So if you drop in CSF, the brain realizes there is a decrease in my pressure, so I need to compensate up. And so there's vasodilatation of the cerebral structures, and that increases the pressure of the brain, but that gives you the headache. But also the kind of headache that we get is because of the stretch of the pain fibers of the brain. And hence we end up getting headache, which is both sensory and vasomotor in tone as well. What has also been noted that there are people who have had a chronic leak of CSF and they've not actually had a headache over 7 days, where they expected the headache to come and the headache never came. So sometimes even a wet tap does not actually equal to a headache, but you have a higher risk of getting a headache. When the patients come, we need to review them as soon as possible. And when we review them, when we review our patients, we need to verify first and foremost to rule out other things that can mimic. In our environment, we have a risk for we have a risk for eclamptic headaches or pre-eclamptic headaches. So you need to be sure that the patient's blood pressure is very normal, but also you need to rule out issues of fever because malaria is very prevalent with us. So common things tend to occur commonly, but also verify the history to confirm if those patients had a needle in their back or a catheter in their back or they had an epidural. And then also ask them in their pregnancy state, did they have any previous headache of the same nature? And half the time they will tell you everything, but also importantly, ask them if they've been previously on anticoagulants. We've had a patient who I've worked on in a private setting with neurosurgeons who, even despite using a small needle, got headache, but they had been previously on aspirin and they had gone through the bridging, but they end up getting a cavernous sinus thrombosis because aspirin was delayed in terms of being repeated. So once you verify that you have a headache, then discuss with the patient the options you have in managing their headache. One of the common things that we encourage is drinking caffeinated drinks. A brew of coffee, which is about 200 mils, will have about 160 milligrams. And also you can ask them if they can, and the different brands like Espresso have 100 milligrams, a cup of tea will have about 40, Red Bull will have about 80, a can of Coke will have about 35. So all these things can be offered if patients want a simpler method of addressing their problem. And the reason we're giving caffeine has blocking the NADP that will end up causing vasoconstriction, and that result in giving them relief from vasodilatation, and that stops the headache. The other drugs that can cause vasoconstriction, we can use caffeine tablets, 300 milligrams 8 hourly, or a high dose of IV, which is 500 milligrams every 12 days. Theophylline have been used, and these ones you can do about 300 milligrams, either orally or IV. The sumatriptans, which are anti-migraine medications as well, can be used between the dose of 50 to 100 milligrams 24 hourly or 8 hourly or 12 hourly, depending on the severity. Plus, we can add on flunarizine to relieve the symptoms of nausea and vomiting. There are drugs that have also been used, which are analogs of adrenocorticotropic hormone like concitropin, and the dose is 1.5 micrograms per kg. Unfortunately, these are not in Uganda. The rest are all available in Uganda. Epiduromorphine versus normal saline have not showed any importance and any help. So pharmacologically, if patients have a lot of tension in the neck, you can give them muscle relaxant like Flexeril. And some patients have responded to epidural fentanyl with hydroxyl starch, and this was a study done in Shanghai. You can also give a sphenopalatine ganglion block, and which I'm going to show a few minutes from now. But also you can give them occipital blocks, which can also be done, especially for patients that are having a confusion between post-dural puncture headache or migraine or tension headache. This sphenopalatine ganglion block addresses the fifth nerve, which is the trigeminal nerve. The trigeminal nerve is very big on our face supply. It supplies the mandibular, maxillary, and then occipital. So literally all your face, right from the chin or the neck to the top of the face, it's supplied by the fifth nerve. So the biggest problem will be around the face, and patients cannot bear. So you can actually use an external block where you can actually give the trigeminal nerve, and it will block off the headache with just about 1% of lignocaine, about 2 to 3 mils. Or you can use 4% viscous solution, which are pharmacologically made, and the patient sniffs the lignocaine in their nose while lying supine, and they can actually end up getting improvement. And this is actually also industrial made and available in pharmacies. The other option, if you're very good at your anatomy, which is always what we call the open book anatomy, you can give just gentle blocks, the supratrochlear, supraorbital, and the auriculotemporal blocks, plus then the greater occipital blocks. So, but it requires you being very good at doing blocks. But this is what we call an open book. You can just look at the surface landmarks and also do these blocks. They are not really a brainer. Now, in 2023, interestingly, among the Canadians, they did a study which was initially found as an incidental finding, because atropine, many patients have been complaining of opioid effects when they are given spinals, and patients who are either not wanting to use fentanyl in their blocks. So someone actually used neostigmine. But what was interesting, they also noted a very sudden decrease in spinal headache. So they went further study and realized that neostigmine increases CSF production, but atropine prevents also NADP that is responsible for causing vasodilatation. And so it increases the production of NADP that causes vasoconstriction on the brain, and hence preventing headache. So they have used this quite a lot around, because we already have neostigmine and atropine, and some people don't want the last resort of giving an injection in their back. And typically, I've seen the higher the dose, the better the relief, but the more the side effects. So my best option has always been 1 milligram of atropine and 1 milligram of neostigmine put in D5 and run at least within an hour. That gives a good relief. They delay of onset of 10 minutes, but patients do not get the effect of nausea and vomiting that will come in when you use higher doses. So just this is explaining the effect when you have vasoconstriction. So the gold standard is what we call epidural blood patch, which is EBP. Epidural blood patch is a non-pharmacological method where you get blood, autologous blood from the patient, from the cubital fossa, or even femoral, whenever you can get that blood, and you back to the procedure, and then you do an epidural just at the site where they had the previous injection. And when you give that blood, it has a mass effect whereby the volume of blood you pushed in will push against the dural puncture, the dural membrane, and increase volume of CSF by pressure, which is mass effect. But also, as you push that blood, some of it will crawl through the dural membrane and end up in the cerebrospinal fluid, and blood in the cerebrospinal fluid causes vasoconstriction. And then also you'll have the sealant effect. So you block the part that has been injected, and the patient lies down, and that shows that actually it works. So it's what we call the gold standard. So you need to be aseptic. You need 2 people, one who will draw the blood and one who will do the epidural. In the event that you have difficulty doing epidural, you can also use an ultrasound if you're not very good at doing this, but also you take consent when you're doing the procedure. There's been several studies to look at what is the best volume and when is the best timing to give the drug. When the drug is given when the blood is given the first 24 hours, about 50% improve. When you give in between 24 and 48 hours, about 65, and the best option is given after 48 hours. And this was a clinical trial and published. And there are also several trials that have been done to see to look at the timings, but the longer the timing, the better. There's also a study that was done as a randomized clinical trial between Australia and Canada, and they looked at about 121 patients and wanted to evaluate what is the effective blood volume between 15, 20, and 30 mils. And the best relief was achieved at about 73. I mean, at about 20 mils of blood volume, and about 73 patients had relief. Now, when you're giving blood, there are stopping rules. If you give blood, we should remember that the spinal canals are very, very different. Some are very compliant and others are not compliant. So when you give, say, for example, 5 mils to the patient's headache disappears, you should not continue giving the blood. If the patient improves at 20 mils, that is very okay. But also if you're giving about maybe 10 mils and the patient starts telling you, I feel paresthesia or I feel pain in the lower back or in my hips, it means you're impinging on the lumbar nerve supplies.
Okay.
Please not continue with the procedure, abort, and allow the patient to lie supine. When they lie supine, it gives chance for the blood to clot, and that will also give a sealing effect. Then the rules that you give the patient when they are going home should be that they should not lift anything more than 5 kilos, because if they lift anything more than 5, it increases intrathoracic pressure, which might close the clot that had sealed to fall off, and then they'll have a repeated leak. But also in the event that have intractable cough and flu, you should be able to treat it so that they do not have a lot of irritation. That will also increase thoracic pressures. What was found that giving too much blood to our patients can lead to hematomas, especially if you repeated a lot of blood volumes, but also can cause arachnoiditis and nerve injuries. So we are required to give the lowest volume possible that will improve the patient. There's been studies where they've compared the epidural blood patch and what we call the sham trials, and maybe done with normal saline. But all these actually do not improve. So if you're doing prophylactic epidural patches, they don't seem to be as good as the actual therapeutic one. So if you've done, for example, a spinal and you realize the patient is most likely going to get a headache, and you say, since now the patient has got a headache, let me give them a patch of blood to prevent the headache. It is not very therapeutic because most patients actually end up complaining of the headache, and that means you have to repeat the procedure. So ideally, prophylactic blood patches or sham patches, which is using saline, are not very recommended. What are the other things when we get these patients having a headache? So averagely, 39% of our patients have had who complain of headache may actually have what we call postpartum headache. There was a review where they looked at about 985 patients and discovered that 39% actually had a headache, which tried to mimic postspinal headache, but actually it was not postspinal. So before we rush to doing big interventions, we may just give them simple analgesics like paracetamol. And then there are those patients that have withdrawal. There are patients, especially in the North American population, and which is happening now with our population in Uganda because people travel a lot. There are people who are drinking coffee. The time when I left as a junior doctor in 20 years ago, you could hardly find a woman drinking coffee. These days, women, some of them drink more coffee than we do. So there are those patients that have withdrawals, and then they'll get a very, very intractable headache, either as a provocation to a migraine or a caffeine withdrawal. So it's good to find out what they've been doing as beverage drinks before, and it's about 4.7%. And yes, so in our review, postspinal headache and tension headaches are very, very common, but also we have late onset preeclampsia headache and PRES, which is posterior reversible encephalopathy syndrome. And these are patients who will also present with history of having had either a seizure or they've had preeclampsia symptoms. But half the time, some of them have had either loss of consciousness or blurry visions. And when you do a CT scan, you'll confirm that there is edema at the posterior side of their brain. Now, if you've given treatment to a patient, maybe 1 or 2 blood patches, we recommend don't go to the 3rd patch unless you're able to do CT scans or MRIs of the brain, but get also a neurologist or a neurosurgeon to involve in reviewing this patient, because half the time we might end up getting you may end up getting more complications with these patients. These are our usual differentials: a migraine headache, infectious headache. Malaria is more common in our environment, caffeine withdrawals, but also sometimes as anesthesia providers, when we give epidural, sometimes we use air and sometimes we cause a pneumocephalus. So any air more than 2 mils is going to give you a headache, and that patient is going to have continuous headache unless you give them hyperbaric oxygen. The headache persists and do not respond to the conventional treatment of the epidural puncture headache. Then there are patients that have cortical vein thrombosis. I shared you an experience. We have had a neurosurgeon who had to request me to review a patient, and patient had been on aspirin. So patients who have cortical vein thrombosis could have been on aspirin. Then by and large, our patients, when they are dehydrated, they'll have a contracted volume of CSF production, and that will end up getting them a compensatory vasodilatation. So improving hydration is very, very key. And sometimes also, if the headache is not responding to all the interventions, we should rule out a subarachnoid hemorrhage, especially there have been history of either being on aspirin, or there've been history of having press, or history of eclampsia. And also we look at the platelets and see. Preeclampsia headache and press and cervical myofascial pain is also very common. Our complications, some patients end up getting radicular pain, which may radiate to the lower part of the back and can be severe in some patients that you may need a spinal physician to review. Sometimes blood has been given and has calcified, and they may still be seen by a spinal thoracic surgeon to see what's going on. And most of these patients, incidentally, who are reported in this case were operated on and they improved. Evidence has shown that lying in bed is not very good. First of all, it's against what we call enhanced recovery against enhanced recovery in cesarean section. So lying in bed is much more worse because pregnant population is itself puts a risk for mothers to get thrombosis, and hospital-acquired thrombosis is about 40% in the Western population, and seems to be increasing in our population. And we've seen the many patients referred to Kawempe with thrombotic events. So lying in bed is not very, very good as a prophylaxis. Opioids do not improve the situation. NSAIDs do not improve the situations, and neither do steroids improve the situation. What is our way forward? We need to be cognizant that this is a big problem. 48% versus 42 means out of every 10 patients end up getting that problem. It's not very good. For hospital economics, it means patients are going to stay longer in bed because there are patients you end up keeping for 7 days, managing the headache, and that means that's not good business for the hospital because that's increasing hospital occupancy. But also in terms of customer satisfaction, if someone has come and gotten which was not part of that deal, it means they are not really convinced the right hospital. We need to be that we need to do everything we can. But also, there are patients that end up getting blindness as effects of craniopathies. So we need to be aware that just when someone gets a spinal headache, it can actually also go into the wrong direction. People will get up lifelong. I request for questions and answers and supplementation from the team. Thank you so much.
Wow, thank you so much, Dr. Aggrey. I'm sure we are all
and that's the takeoff message in short.
Thank you very much. We are saturating with the knowledge, Dr. Aggrey, and you have a lot of flowers and hand claps coming up for you. The number of questions in the chat, I can start with a few hands. We have only a few minutes to close our session. So, I seem to only see flowers and buckets of popcorns, and I'm not seeing hands up in the question. So in the chat. So let me start with the ones in the chat. Among participants, I'm not seeing any hand up. I know you said opioids may have limited role, but someone is asking, what's your take on betapine and fentanyl patches? In situations where people cannot access all the other modalities that you have taken us through, Dr. Aggrey.
So one of the things that we actually readily have is caffeine. Caffeine is readily available either as a drink, as a beverage, but also Cafe Goat. Cafe Goat is an anti-migraine medication that has caffeine and tartarate. Caffeine about 100 and tartarate about 10 milligrams. So it's sold as a ratio of 100/10, and you take one tablet every 6 hours. Most of my patients in low limited setting is what I normally recommend because it's quite readily available and it causes vasoconstriction. But also neostigmine and atropine are already available literally in all anesthesia providing centers because they are being provided by the NMS. So beta-pine, fentanyl patch have no role because if you look at the mechanism of the headache, they do not cause or reverse the vasodilatation that is happening, but they may give you some offer of relief. So the relief the effect in terms of pain may be that the sensory nerve endings of the brain may be improved, but the effect of getting nausea, the effect of getting the neck pain may not be resolved. The muscular effects of the that come out of that come after the dural puncture. So there may be some relief after about 50%, but there may not be complete resolution.
Okay, thank you, Dr. Aggrey. And the rest are all are remarks on how people are very grateful for the presentation. I think some of them you've already answered in the chat, and I want to thank Blamba Fred Fry. I think he's an anesthesia provider. He has also helped us answer a lot of, well, the other questions in the chat. So thank you. I still don't see a hand up unless I am missing. Yes, there is a hand from Pascal Tembo. Tembo?
Thank you so much, Dr. Najemba. Thank you so much, Dr. Najemba. Thank you so much, Dr. Aggrey, for the insightful presentation. It's really been helpful. Thanks a lot. I would like to make a comment on just a few things on PDPH. And I wanted to talk about whoever could be interested in placing an auriculotemporal nerve block from the tragus of the ear. One finger breadth will make you appreciate the pulsation of the temporal artery, and so a centimeter away from your finger will be able to give you the right spot to drop your local anesthetic to be able to block the auriculotemporal nerve. And then the non-invasive SPG block, have your patient in supine, drop 1%. I usually give 5 mils of 1% lignocaine and drop it at the middle turbinate in the nose, and it has to be bilaterally to be able to achieve maximum effect. However, you might have a spill at the oropharynx, and your patient might tell you that they are feeling the flow into their mouth, but it's not always very significant. So the non-invasive SPG block is quite easy to place and can give you results in a few minutes. Thank you. Thank you so much, Dr. Aggrey.
Thank you so much, Pascal Tembo, for sharing those practical experiences. And I think they are easier to do in our environment.
Yes, thank you, Tembo, for that, for those complimenting submission. And I believe our participants have gained from that, and for complimenting on the presentation. Thank you. Dr. Aggrey, I don't see any more.
Chat room.
Sorry, Kemgisha, do you want to ask a question? Hello? I seem not to see any more hands up. Kemgisha, is that a question?
Thank you so much, Dr. Aggrey, for the presentation. I would like him to repeat the name of the drug that he says contains caffeine.
It's called Cafegot. CAFEGORT. Cafegot. It has caffeine and a glutamine, and it's normally written as 100/10 milligrams. You should prescribe 1 tablet every 6 hours, and don't exceed 4 tablets in 24 hours before you repeat the dose. Normally, most patients, after the first 2 doses, they feel 100% relief.
Thank you so much.
It's normally as a yellow, slightly bitter tablet, but it is not real 100% bitter. It's like paracetamol bitterness.
Thank you, Dr. Aggrey. Yes, Rose, you've been answered. Can I get two more questions? Then we close the session. No, please, you must raise your hand up. Dr. Aono Mary, followed by Senguzi Nicholas. Kindly mute if you are not chosen.
Thank you so much. I was asking if there is a role of caffeine citrates.
Yes, I use it quite a lot in Kawempe, National Referral. It's what we have. Normally, it is about 10. We have the smaller concentration of 10 milligrams. So a few times, the pharmacist always wonders why I use about 50 milligrams, which is like 5 vials. But yes, it is very good. So the smaller dose will not have much. You need to have a little more dose. So about 5 vials. If you can get 10 vials, that would be close to the usual dose. But we recommend about 500 would have been good, but we have the lower volumes. And it would be very good as a study.
I meant codeine sulfates, not caffeine citrate. Codeine.
No, codeine is a low dose opioid. It has no role.
Okay,
I told you
thank you.
opioids have no role, steroids have no role.
Thank you.
Musinguzi Nicholas.
Okay, thank you very much, Tim, and thank you very much, Dr. Aggrey. Mine a little bit goes a little back on total spinal. So especially on the transportation of a patient for a long distance from, let's say I'm referring from approximately like 50 kilometers for up to a national referral, let's say Kawempe. Because I've had a scenario of transporting a patient from Kisenyi Hospital up to Kawempe, especially on an arm bag. Doctor really needs some guidance on how best it can be done, especially a patient who has had a total spinal, is intubated, and with our ambulance system where it doesn't have a mechanical ventilator, and you are typically on either a reservoir arm bag on transporting that patient. How practical is it? And is it possible to achieve it? Thank you very much.
It is. Thank you so much for the question. I gave you an example of someone came from Chenjojo. The first important thing is when you get a total spinal, you secure your patient's airway. The next thing is to maintain cerebral perfusion. And that means you're going to make sure that your blood pressure and volume flow are very good by either running a vasopressor plus or minus an inotrope to maintain cardiac function, because also sometimes the cardiac stops. Thirdly, you need to stop further complications of hypoxia to the brain by giving anticonvulsants. That means can be Valium, can be midazolam, can be thiopenton, can be phenytoin, and magnesium sulfate, as long as you keep watch of your blood pressure, because it will cause you hypotension, and which you don't want for cerebral perfusion. Now, intubation is very good because you are now you're sure that you're maintaining perfusion and preventing hypoxic state. So when you intubate, you make sure you tie with strapping, but also tie with gauze. So you reinforce that the tube may not have to be moving. Ambibag as a mechanical ventilation, as a form of ventilation, is very effective as long as you maintain the normal breath per minute for that patient characteristic. So for pregnant mothers, a breath between 20 to 25 breaths per minute is good enough. And just an average good tidal volume, maybe of about 400 to 600 mils, because they will vary depending on each punch of each squeeze of the bag. If you are lucky to have mechanical ventilation, that's okay. Then the other thing also which you should normally do is to inform the receiving site of what has happened, so that they prepare everything in advance and a mechanical ventilator for you, so that when you come, everything is ready to set and ready to receive that patient, so that there is continuity of care, as opposed to when you come and then they don't have a ventilator and you're already frustrated, you're already tired, and then they need to refer, because we've had a situation where bombers referred and we have to again to refer to Women's Hospital, because in the past we've only had one mechanical ventilator. So if it's already under use, we wish someone would have called us and saved that extra time than just traveling. So it's always good to call to the receiving site that they can prepare and know what to expect, and also how to improve the patient's condition, and also give them the drugs that you've used so that they can look for other extra drugs in the event that they can save that.